Okay, so we're going to be talking about robotic assisted total hip replacements, and in particular, the advancements in technology that are available to us today. So it'll be hopefully a nice discussion. And like Brett mentioned earlier, there's probably going to be some questions. So feel free to hold on to those questions or write them down. And at the end of our talk, we'll open up to question and answer, and we can go through them. So my name is Ghassan Bogosian. I am a board certified orthopedic surgeon. I did a fellowship in hip and knee replacements at Cleveland Clinic about a decade or so ago, moved out to the desert and have been here since. I practice currently at Eisenhower Medical Center, and I'm one of the fellowship trained surgeons over at Desert Orthopedic Center. There we go. So what we're hoping for and striving for these days is that we don't end up with a hip replacement that someone is unsatisfied with. And we're looking for hip replacements that what I call, or what the industry calls, is the forgotten joint. So we want your hip replacement to be a joint that you don't even recognize that you have, and you can get back to a normal quality of life and you don't even know it's there. So innovation today creates tomorrow, and tomorrow is here today. So that's an important statement, because as you think about our past and our future, you know, we've obviously advanced a lot in the last couple of decades. And, you know, what we have at our fingertips today is technology that we really didn't have previously. And it's really allowed us to innovate and create medicine that will allow patients a better quality of life. So topics of discussion today, we're going to break it down into first talking about just arthritis. What is it? What does it mean? What's the definition? What does it look like on X-ray? What does it feel like? What are some of the non-surgical management options that can be used to treat arthritis without surgery? What are the approaches? Because that's often a big topic. And then, of course, we're going to talk about what is a standard hip replacement in the first place. In order to speak on robotics, you have to understand how a standard hip replacement is performed. And then, of course, lastly, we'll talk about robotic surgery. So what is hip arthritis? Arthritis is the lack of something. Most people think it's the presence of arthritis in my hip. It's actually the loss of cartilage in your hip. So we're all born with a layer of cartilage on the ends of our bones, where the two bones come together, whether it's a knee or shoulder or hip. And the absence or the loss of said cartilage is what causes arthritis. It's what causes pain. Of course, when arthritis is gone, all of a sudden you have exposed bone, and that exposed bone becomes very painful when it rubs against each other. So this is what it looks like on X-ray. And on X-ray, when we see that space between the ball and the socket, that space is not just space, it's actually occupied by cartilage. You just don't see it on the X-ray. So this is what it looks like. That space between those two red lines is indeed the amount of cartilage space that we have inside of our joint. So that's a normal looking X-ray. That's what we want to see. This is not a normal looking X-ray. This is a patient with a severely arthritic hip. And as you can see here, not only do you see the irregularity in the hip, but you can also appreciate the fact that this person is bone on bone, that this person has bone spurs, or what we call osteophyte formation. They also have cystic changes, which are a little hard for the average individual to see. And these signs all cause hip pain, and they typically will cause pain along where this patient is grabbing along their hip. So it's pain that goes into the groin, pain that can sometimes radiate to the side of the hip or even to the back of the hip. But most often presenting symptom is the groin. And this is a little diagram that I like, because there's a lot that can happen in the hip joint that can cause pain. And there's so many structures around the hip that can cause pain, whether it be the back, whether it be bursa, sacroiliac joint, it can be, tendons around the hip. And a very small area is typically caused by osteoarthritis, and that is the groin and pain that may come out to the side of the hip. On physical exam, it's fairly easy to diagnose for us in the office. It's typically pain in the groin with rotation of the hip. So as you see, this patient is laying on their back, and the doctor may pick up the leg and flex the hip or bend the hip up to about 90 degrees. And then we rotate the leg back and forth. If we can reproduce pain, or if there's noted loss of range of motion, i.e. the hip doesn't even rotate that far, that's usually caused by hip arthritis. Most of the time, patients will come into our office and think they have hip arthritis, and they point towards their low back, pointing over the back of their pelvis. That's not really hip arthritis. That's usually something caused by sacroiliac or by piriformis or radiating pain that comes from the low back. So again, reproducible sign of osteoarthritis is pain in the groin and pain with rotation of the leg or lack of rotation of the leg. Most patients will say, I can't even get in and out of my car anymore because my leg doesn't swing out to the side, or I have a hard time tying my shoes, and so on. So again, golfers will report the same thing. They'll say, I could twist at the upper body, but I have a hard time twisting at the pelvis because there's no rotation. So let's talk a little bit about some of the non-surgical management options. Those options are, of course, activity modification. So if you can't do activity X, then you avoid activity X. And that, I guess, goes without saying. Weight loss. Weight has a tremendous effect on patients with arthritis. There's said to be a 7-to-1 ratio. So for every 1 pound of weight that you lose, you take about 7 pounds of stress off your joints. So that's always helpful. Exercise. If you can move, you're a frequent exerciser, you lubricate the joints well, that is definitely a good adjunct to minimizing the pain caused by arthritis. And then non-pharmaceutical agents such as joint juice, glucosamine, chondroitin, turmeric, all those things can be helpful. Of course, in the early stages and the later stages, it's not as helpful, but in the beginning it is. Over-the-counter medications like say naproxen, Aleve, of course, Tylenol, specifically some of the non-steroidal anti-inflammatory medications can help, but keep in mind they all have side effects too. So you take too much Aleve or ibuprofen, you can get an ulcer. So you have to be careful with these medications. And then of course, prescription medications like Celebrex, and very rarely we use things like Tramadol or pain pills or narcotics. We try to stay away from those. Once you start using narcotic medications to address your pain, you should start really thinking about surgical treatment instead of non-surgical treatment. And lastly, cortisone injections. Cortisone is a powerful anti-inflammatory medication. And what it's doing is it's treating the inflammation caused by the bone-on-bone disease. It's not fixing the arthritis and it's not getting rid of the bone-on-bone disease. But those two things, the arthritis and the bone disease, cause a lot of inflammation. And so what the cortisone does is it quiets that down for a brief period of time. For some patients, it may work for 3 weeks or 3 months. And for others, it may work 6 months or 9 months. So we use that at times just to at least test the diagnosis, or if nothing else, treat the pain if someone has, say, a wedding coming up or a travel plans coming up and they want to postpone surgery. All right, approaches, that's a big topic. Patients always come up to us and they say, in the office, and, what approach are you going to use? And this is very confusing for patients, as you could imagine, because there's so much literature on the internet. And I'll tell you what, don't believe a lot of what you read on the internet. There's a lot of false or misleading information out there for a variety of reasons. And, that there's traditional approaches to hip replacement surgery, and then there's kind of modified approaches. And there's really a lot of them out there. So there's the anterior approach, which you've heard a lot about. There's the Watson-Jones or anterior lateral approach. There is a traditional posterior approach, and then there's also the mini posterior approach. And some of these are, traditional approaches with regards to their invasiveness. I hate using that word, but that's what it is. And there's others that are truly minimally invasive. And so when you think about the traditional approach, it's a long incision that allows the surgeon to really open up the hip and really see everything inside that hip. And it's great. It's a workhorse. We use it a lot in big cases and big revisions and really complex surgeries where we're going to be in there for a couple of hours or 3-4 hours doing a very unusual case, and we need to see more. But for the standard hip replacement, someone who, just has arthritis and good old fashioned normal wear and tear, we do one of two approaches. We do either the anterior approach or the mini posterior approach. And these are both mini approaches with smaller incisions and muscle sparing and muscle protecting approaches that allow the patients a quick recovery. The patients who have these approaches are typically up on their feet right away in the recovery room. They're up walking, and I think currently our statistic is such that 60-70% of patients who have surgery on a day will go home on that same day. And usually within just a few hours of their surgery, they're in the recovery room, feeling great, going home, and they do fine. They do great. They got a walker for a few days, they do a cane for a few days, and then before you know it, they're back on their feet doing wonderfully. So the two, in my opinion, minimally invasive approaches are the direct anterior and the mini posterior. So what is conventional hip replacement surgery? What really does that mean? What's a hip replacement, and what does it mean for the patient? So when we talk about hip replacement surgery, you have to understand that what we're doing is we're removing the ball and we're reshaping the socket. And in order to do that, we have to first get in the hip. So when we get in the hip via one of the approaches that we discussed before. And what you can appreciate here is that this is an acetabulum, or a socket that is worn out. You could see the red and inflammation and worn out lost cartilage. And the way to remove all of that is that once we've opened up the hip and we've exposed it, we take this reamer, and a reamer is basically a reaming device, or a cheese grater, if you will, that is on an end of a drill, and we ream away all of the bad cartilage and the bad bone, and we make it a perfect hemisphere. Once we do, we can put in this beautifully hemispheric cup that is perfectly round. It's very well engineered. And we put in a liner or piece of plastic that becomes the bearing surface of that cup. And that gets impacted into the cup. So the two become one, and they become attached or fixed to the pelvis, okay? And that becomes the bearing surface. And what you're seeing here is on the back of this cup is a material that allows the bone to actually interdigitate and grow into the cup. On the femur side, the top of the ball gets cut off. We place the implant into the center of the bone. We place a ball on top of that implant, and those two pieces become one, and that gets pushed back into the socket, and that becomes the new hip. And so there you go, range of motion of the hip. We make sure that, number one, we've made the legs nice and stable. We made the legs nice and even. We check for things like impingement to make sure the ball or the neck of the stem doesn't impinge against the socket. We don't want you, squatting down and having the implant touch the femur or the pelvis so that it causes pain. We also want to make sure that your hip doesn't dislocate or pop out of socket. So the experienced surgeon, when doing the surgery, will always check for these things to make sure none of those adverse things are happening. So this is what it looks like after surgery. We've taken out the ball, we've taken out the socket, we've put in a metal stem. The metal stem goes down the center of the canal. We put in a cup and then a new ball. Meanwhile, we're doing all of this, we're making sure that a lot of things are done right. And that is, the length of the legs are even, so that the leg that we just operated on isn't all of a sudden longer, or the offset of the hip, meaning the left to right distance of the new hip, isn't greater than the other side, because that can cause problems. If it's too high, it can cause bursitis, and if it's too low, it can cause dislocation. So there's a variety of parameters that we're looking at. We're making sure that there's no impingement, as I mentioned earlier. So here are some of the variables that we're looking for. This is a hip replacement of mine that I'm showing, and I want to kind of share with you some of the things that I look at when I'm looking either in surgery or post surgery when I'm looking at the X-rays. So we're looking at here is the cup size, and you'll notice the size of this cup demarcated by that red line is perfectly sized for this patient's cup or their acetabulum. And because we do this robotically, we have a CT scan that you obtain as a patient prior to surgery. We'll talk more about that later. From the CT scan, I can build a three-dimensional model. And now, instead of making judgments on a two-dimensional X-ray, I now have a three-dimensional model which is sized, and I can figure out exactly what size cup to put in this patient. And these cups and implants don't come in small, medium, large, as you know. They come in 2 millimeter increments. So there's a perfect size for every single patient. So the next thing that we look at is the cup position. And what we're doing here is we draw a line across the bottom of the pelvis, and we draw a tangential line across the face of the cup. And typically what we're looking for is somewhere between about 40 to 45 degrees. And this happens to be at 43 because I did this robotically, so I know it was done perfectly. So that's kind of what we're looking for. But this is what we call a well-placed cup. If it were, say, 70 degrees, that would be too vertical, and that would cause a dislocation. If it were any less than 40 degrees, it would be too horizontal, and that would cause impingement. So this is about the sweet spot. It's safe, it's not going to impinge, and it's very safe from dislocation. And then we also look at version. Version is the openness or the faceness of the cup, how far forward it's rotated or how far backward it's rotated. And typically what we're looking for is about 20 or 22 degrees. And again, with robotic surgery, we can dial this into the exact number. So if I want 22 degrees, I can set that to 28 and the robot will help me get there. And then the stem size, again, when you see the red line here across the width of the stem, you could see that this implant is perfectly positioned inside the femur. It's not too big, it's not too small. It's going to sit right where I left it. If it's too small, it's going to subside or fall down into the center of the canal as soon as the patient stands up and walks on it. If it's too big, it's going to sit too proud. And if it sits too proud, guess what? It pushes the femur down because the implant can't go down the femur, and therefore the leg becomes awfully long. And of course, the patient complains of a leg that's too long. So there is a sweet spot or a happy medium, and with robotic surgery and a well-experienced surgeon, we can make sure that that implant is well sized to the femur. And then the stem position, same thing. We want to make sure that it's going straight down the canal. We don't want it sitting at an angle, and we can fine tune its position using robotics as well. So let's look a little bit more about leg lengths. And this is a patient who has arthritis of the left hip, which on your screen is on the right side. And this patient is short on the left. And the way I see that is by drawing a red line across the bottom of the pelvis to level the pelvis. So now I can see that the pelvis is level here. And then we draw a short line that goes up to the lesser trochanter on the non-operative side or the non-arthritic side, and then another one on the arthritic side. And then if you compare those two lines together, you could see that the one on his left side is higher, which tells me that that leg is shorter. Okay, so our objective in surgery is to make it so that that red line, once slid up to the lesser trochanter, intersects the trochanters right in the middle of both hips. And there's what the post-op x-ray or post-surgery x-ray looks like for that patient. So what could possibly go wrong? Why do you need robotics? That sounds so straightforward, right? Well, it's not always the case. Here's a patient. These are fortunately not my cases, but I'm going to show them to you anyway. This is a patient, as you could see, the line transects the lesser trochanter on the left hip, but not on the right. And that tells me that the hip on the right is actually longer than the hip on the left. So this is a patient who's going to need a shoe lift on one side to make them even again. Here's another patient who you could see on the right leg, which is on your left side of the screen. It transects the lesser trochanter, while on the right side of your screen, it does not. The lesser trochanter is below it. And again, this leg on the left is longer. This patient will need a shoe lift on the right leg to even them up again. And the other interesting point here is, and I think you're going to see it with the next x-ray, this one especially, is not only can you appreciate the fact that this is, I don't know whose x-ray this is or whose patient this is, and I'm just going to say it, it's atrocious. This is a patient who has a relatively normal looking hip on the right, but their left hip is significantly longer, probably a full inch or inch and a half longer. But more so than the leg length complication here that you see, the offset, that is the left to right distance of this hip, the position of this hip is so offset to the right side of the screen that this person's going to have bursitis all day long. They're going to hurt. The side of their hip is going to hurt and ache the whole time. So those are the things we want to avoid. We want to make these as precise as possible. And I'll tell you, a good orthopedic surgeon can fine tune these things just by means of their own expertise. Because they've done so many of these, they can kind of feel what's right and what's wrong, and they make intra-surgical or intraoperative changes on the fly. But with robotics, you can now make changes down to the millimeter or even sub-millimeter, and you can really dial in differences between lefts and rights and impingement and dislocation risks and so on. So let's talk a little bit about robotics and what it means. Obviously, we live in a new era of medicine, right? This is an evolution and a progression of medicine that hasn't been available to us in the past. And in the 1960s, 70s, 80s, and even really early 2000s, we didn't have this, and robotics was at its infancy, industry-wide, not just in medicine. And now we live in an industry where things have evolved quite a bit. We have watches that can talk to us, watches that can do an EKG right from our wrist. We have telephones that are basically the bridge between us and the rest of the world. God, any question you want to have an answer to, you can now have an answer to it in just 15 seconds by asking the SIRI next to you. I don't want to say it because she'll respond. And then, of course, we have cars that drive themselves. I mean, who would have thought that 20 years ago we'd have vehicles that you can just sit behind a wheel and hit on your screen address in Los Angeles, and it just takes you there. We're about there. I mean, the technology exists as soon as the transportation folks allow us to turn on that feature. I tell you, Tesla will turn it on and we'll be able to do it. So robotics, we've come a long way, baby. I mean, this has been used, gosh, for a decade now in the automotive industry. You don't see people putting cars together manually anymore. But in Detroit, this is what inside of a factory looks like. So why not in orthopedic surgery? Why not in general surgery? The technology is available to us, and we can start using it. So let me introduce you to the Mako, M-A-K-O, by Stryker. Mako is a robotic platform that's used to precisely put in hips and knees and soon shoulders for the Stryker system. It was a company that was independent, founded originally in 2004 in Florida, initially developed for partial knee replacements, and it was acquired quickly by Stryker in 2013 for a good chunk of change, as you could imagine. So this is a video. Let me hit play, and then I'll take you through it. I thought this did a really good job of demonstrating the technology. So I'm going to mute this, and I'm going to just kind of take you through it a little bit. So this is the Mako robotic system. So here's the surgeon standing behind. It gives you kind of an appreciation for how big it is relative to the doctor and then in the room. And the same robot could be used for partial or total knee replacements as well as total hip replacements. What you're seeing here is the hip application with the reamer that goes into the socket. And remember what I said earlier, you get a CAT scan that builds a three-dimensional model of the patient's pelvis or knee and allows us to kind of see the whole thing in a three-dimensional view. So prior to even coming into the operating room, we can build this three-dimensional image. And just like an architect could design and build a house on the screen before this house is even built, we could do the same thing with a hip or a knee. And I can remove the arthritis. I can add the implants exactly where I want them. I can make micromillimeter adjustments on the screen before I even entered the operating room. So when I enter the operating room now, it's just about surgical execution. What I do when I come in the operating room is I have to tell the robot where your anatomy is in space. So I take what's called a probe and I start probing the parts of the femur and the parts of the socket, parts of the acetabulum and femoral head. And then within about 10 minutes, the robot knows exactly where your body and your anatomy is in that room, in that space. So there's a verification and a registration process that becomes that helps the robot understand where things are in the room. So when the robot comes in, and you can see the surgeon here on the left holding the robotic arm, the robot is on my right. I'm positioning the cup or the reamer into the socket, and you can see all the numbers there in green, and it's giving me feedback, immediate feedback as to what's happening inside that body. Nothing happens unless I pull the trigger. And if I try to override somehow and do something that the robot feels is out of my suggested plan, the robotic arm shuts off and does not let me execute that plan unless I take it out, move it out of the way. So this is the cup going in. The cup goes in at an exact perfect angle that I've intended. Remember that plan that I did before the surgery? I told the robot, this is what I want. The robot comes in, and like a CNC machine would do its work, a robot comes in and makes those cuts precisely. So it's, it's technology that is really changed how we do things in the last decade or so. And the accuracy with which it allows me to do a hip replacement or a knee replacement is beyond belief. I don't, I consider myself a good surgeon. I have always done good hip replacements and knee replacements. But this even, for us who think we do good work, this has made us so much better. So here's a couple of case examples. This is a patient who came to me. She was actually young. She had 23 millimeter discrepancy between her right and her left hip. You could see on the right side, which is on the left of your screen. She had a discrepancy of about 23 millimeters. That is about an inch, 25 millimeters in an inch. And so she had a congenital deformity with which she was born, leaving her quite short. Her hip was very, very painful. She couldn't walk on it. She actually had 2 little children. And we finally decided, you know what, even though you're young, we went ahead and gave her a new hip to improve her quality of life, improve her gait. Her back was starting to get affected by the large defect. And so that's what we did. So 23 millimeters. Planning wise, I can put the stem in exactly where I want it. I can plan to, whatever stem size I want, whatever angle I want, and so on. Same for the cup. I can position the cup exactly where I wanted it and make all these micromillimeter adjustments. During surgery, I can make small adjustments as I get closer and closer to my intended goal. You can see here, I've already lengthened her by 16 millimeters. She's still 7 millimeters short. Couple of more changed. Uh-oh, I'm missing an x-ray. Here we go. So this is out of place, but I'll show you the array. This is the femoral and pelvic array that goes on the patient's pelvis so that the robot can communicate with me during the surgery. And then this is where I finished. So I lengthened her hip by 23 millimeters on the operative side, and I left her 0 millimeters different than her contralateral or opposite side. So I made up the whole difference, and she was able to finally walk even without needing a shoe lift and got rid of all her pain. This is a fun case. I think I like showing this just because of the ending. This is a patient who came to see me on their left hip, which is again on the right side of your screen. They have severe osteoarthritis, severe bone loss, and cartilage loss. And really, this is, I could tell from an x-ray that this is a hip that hurts quite extensively. You could appreciate here that not only is there arthritis, but there's a loss of limb length, and this patient's hip is also shortened quite a bit. This is him prior to surgery.
Okay, thank you. There we go.
That was pretty choppy on my end. Brett, can you see it okay?
Yeah.
Okay. All right, this is him prior to surgery, and this is his hip replacement after surgery. Again, it's the one on the right side of your screen. And of course, leg lengths are even, but more importantly, I was able to get rid of that god-awful arthritis that was causing him so much pain and limp. And this is him after surgery by, I think it was, he's gonna tell us, it might've been 2 weeks. Okay, Donald, welcome back. When was your surgery? How many days ago?
2 weeks and 4 days.
Perfect. All right, come on up for me.
Okay.
There you go. Go take a walk.
I'll fix.
Good.
Now I can dance.
There you go. He's ready to dance.
We're gonna do good.
You guys are cute. I love it. Thank you.
We celebrate 55 years next week.
Congratulations. What a blessing. He's a longtime patient of mine and just an absolute wonderful human being, him and his wife both. So I enjoy sharing that video. Well, that's the gist of it. I mean, we can open it up to questions. I hope you guys enjoyed a little discussion and what I thought was an intriguing topic of robotics and hip replacement.